Alright, so we want to look at another joint issue which we are here to discuss, and this is what is known as developmental dysplasia of the joints. Developmental dysplasia of the joints. So for the developmental dysplasia of the joint, you just have to do it. Okay, you're actually talking about the hip, congenital hip dysplasia. So the femur is not into the acetabulum again. So it just has to do it. Most commonly, you are trying to talk about developmental dysplasia of the hip. Okay, so it's a condition where the hip does not form properly, leading to instability and subluxation. It's sliding out. Okay, so it's the most frequent orthopedic condition in newborns. So what is the developmental dysplasia of the hip, which is another name for what? Developmental dysplasia of the joints. Is what? Abnormal development of the hip joint where the femoral head and the acetabulum, they are misaligned. So this is causing a lot of instability. So it ranges from mild shallow socket to complete dislocation. It could be that it is inside, but the socket was not deep. So there's some instability, but not that much. And totally, it could be that the two things are disconnected. So it was previously called what? Congenital dislocation of the hip. Alright? So epidemiology, you see it in 1 in 100 newborns. So it's very common. Right? Dysplasia, you see it there, very common. But the main dislocation, okay, is 1 in 1,000. It's more common in females. 6:1, common in Native Americans and the lamp-ladder population. So risk factors is all those breech presentation, family history. So you could actually run in a family, firstborns, okay, because your mom's birth canal is still tight, so these issues could possibly come up. So, diagnosis is limited hip abduction, asymmetrical thigh, and gluteal. If you look at the two sides, one is up, one is down, like the legs, one is up, one is down. They do the Ortolani and the Barlow's test. So, imaging, you can also do ultrasound and x-rays just to look at the degree, So, treatment, you do all those Pavlik harness, then also close reduction under anesthesia, followed by the speaker casting. Okay, so that's what we got for this.